My name is Nicole Sparty-Burr, and I'm the Director of Research at the Adenoid Cystic Carcinoma Research Foundation. I am pleased to introduce this presentation by ACCRF grantee Dr. Daniel Pelaez from the University of Miami, in which he describes a liquid biopsy test that he's developing for ACC patients. Liquid biopsies are blood tests that detect tumor cells or fragments of genomic material shed from tumor cells, which may circulate in your bloodstream. The major advantages of liquid biopsies compared to traditional biopsies are that they're less invasive than a tumor biopsy and may provide information from multiple tumors in an individual patient. Dr. Pelaez's liquid biopsy test looks for MIB fragments in patients' blood. MIB is a cancer gene that is overexpressed or too abundant in almost all ACC tumors, so this test can be relevant to almost all ACC patients. So how could this test be useful? First, for new patients, it might help make an ACC diagnosis. Second, for newly diagnosed ACC patients, the test might help suggest their prognosis or how advanced their cancer is. Third, for ACC patients who have had surgery and possibly radiation to treat their primary tumor, the test, alongside MRIs and CT scans, might help monitor whether the disease has recurred. And fourth, the test might indicate how well an ACC patient is responding to therapy, whether surgery, radiation, or a drug treatment. Clinical trials will determine whether these exciting possibilities for easing the ACC patient journey will come to fruition. We thank Dr. Pelaez for his efforts to help ACC patients and for explaining his latest work in this presentation. Thank you for your interest.
Thank you so much, Nikki and Jeff, for inviting me to give this talk. I'm very excited to be here. As advertised, I'll be talking about our work in the development of new liquid biopsies, specifically for the detection of metastatic adenoid cystic carcinoma. And then at the end, I'll talk a little bit about development of additional biopsies or diagnostic tests that we've been developing, as well as how these have been translating into new knowledge about mechanisms of how these tumors progress and how we're using this information for novel treatment therapies. So to start off, I have a couple of disclosures. Some of the stuff that I'll be talking about today are covered under some provisional patents, and I also do some consulting work for biotech companies. I won't dwell a lot on adenoid cystic carcinoma. I'm talking to a pretty savvy group here about what underlies the disease, the known risk factors. What I will be focusing on are limitations and points of optimization in diagnostics for both primary and metastatic disease. So how do we detect and surveil for recurrence and metastases, as well as how these may translate into novel treatment options. So let's start off with how normally cancers and ACC are diagnosed. These are most commonly through tissue biopsies. So what we would get is a patient with a mass growing in a gland. Unfortunately, in head and neck glands, when we have a presentation like this, right now we have 18 different possibilities or 18 different diseases that we have to decide amongst. 40% or roughly 40% of those are benign and 60% of those are malignant. So that requires us to go deeper into the lesion and look at what we're actually dealing with, which will then inform management of the patients. Now, for both primary tumors as well as metastases, traditionally this requires a surgical excision of a little chunk of the tissue, sending that to a pathologist that puts it on a slide, adds a couple of histological stains on it, and then takes a look under the microscope to see what we have. This is a classic example of what you would get in a pre-treated tumor, where you have foci or regions of cancer cells intermixed with normal skeletal muscle cells, some scar tissue that arise from pre-treatment or chemotherapeutic treatment of the tissue, as well as normal nervous tissue. So there's a big admixture here, and the proportion of cancer cells to normal cells varies quite a bit depending on the size of the biopsy, as well as the excision and the location and the treatment conditions. So there are some limitations to these traditional methods. One is that tissue pathology itself can be a little bit equivocal sometimes. Interpretations vary from pathologist to pathologist in certain diseases. ACC is one of the more common ones, or one of the more easier ones to diagnose, but there are some limitations sometimes amongst pathologists to decide whether they're looking at ACC versus, say, a pleomorphic adenoma. These arise specifically when you have subtle or microscopic disease that can be intermixed with normal tissues. So if the foci of malignant lesions are very small, sometimes the pathologist can miss them, or they can go undiagnosed. Similarly, with imaging studies, so imaging studies can tell us that something is growing within our bodies, but they are very limited in telling us whether it's a benign or malignant lesion. And here are some examples of things growing in the orbit or in the lacrimal gland where the pathology ended up being benign or malignant, but we can't really tell from imaging studies. So these require tissue biopsies. And in the lungs or liver, where these things, where ACC normally metastasizes to, we can see growth, but an ultimate tissue biopsy is necessary. In imaging studies, there is a limitation for microscopic disease. So depending on the imaging modality that's being used, we could detect lesions that are half a centimeter in size to a centimeter in size. But microscopic disease is normally not picked up. And that's why recurrent or periodic screenings are required, which then goes into the costs and logistics of maintaining these periodic imaging screenings undergoing for patients with ACC. So for many years, the field has been moving into molecular diagnostics. So these are things that pathologists can tack on, looking at specific molecules that identify diseases. Traditionally, this is done through immunohistochemistry, where you use antibodies against a specific molecule that you know that the tumor expresses or should have. In the case of ACC, the most common one is looking for overexpression or the degree of expression in MYB. So here you're looking at brown spots, looking at MYB immunoreactivity in adenoid cystic carcinoma. And this is one of the most powerful tools for us to discern between something like a pleomorphic adenoma versus an adenoid cystic carcinoma. These offer obviously a lot more objectivity, so they're not reliant on pathology experience or interpretation. They can be a lot more sensitive than just looking at things under the microscope with a general histological stain. And as you'll see, they can be developed in a non-invasive way. So we can actually assay liquid compartments within the body and look for molecular evidence of disease, as you'll see in our development of the blood biopsies. But where do we look for molecular signatures of cancer? So traditionally, this is the general dogma in biology. And this is how I teach my undergrads about understanding how the molecular dogma works. So if you think about the DNA or your genome as being a blueprint and instruction manual for how to build and maintain a human body, the RNA tells us what parts of this book are being read, because not every single tissue needs to read the entire book, even though every single cell in your body gets an entire copy of the book. But if you think about a pancreatic islet that only needs to create insulin, that cell probably doesn't need to read the chapter on how to create contractile structures for muscle. So what they do is that they bind those sections of the book together. They physically glue them so that they're not accessible. And that way they only have access to the sections of the instruction manual that they need. And then the proteins tell us what is actually being translated or made from these instructions that are being read, what is actually being produced at the functional level. And then proteins, through different metabolic processes, go and modify either sugars or fats. And the combination of all these plus the nucleic acids make up our entire body. So if you think about the instruction manual and genes as being words that instruct us to build something, and this is a simple example. So if you think about the instruction reading cat, the RNA would read the letter CAT, and then the proteins would go on and assemble a CAT. This is what happens in a normal gene. Now, unfortunately, in cancer, when things go awry in any one of these processes, you can have different alterations, and these have many different flavors. So I'll go over a couple of them. You can have deletions or substitutions that end up making no sense, right? So CT is not a word that we can understand, and then nothing gets produced. You can have substitutions where one of these words is miscopied as a cell divides. It has to make several copies of this whole instruction manual. And if you think about millions and millions of cells or millions and millions of copies of this book being made, it's very prone. Nothing in biology is 100%. So there's some probability of some um, errors occurring. So one of those is a substitution that would instruct then the proteins to make something other than what it's normally meant to make. There are insertions where sometimes as we're reading or copying this book, you add another word or another letter to that instruction manual, and again, you end up making something different. In the case of ACC, there are things that errors that cause multiplications or amplifications of a particular word. So rather than having one cat, you end up with 3 copies of that word in the same sentence, and then your proteins make up or end up making 2 additional copies of that protein, which should not be there in that dosage. And then you have another alteration that can occur in which, as you copy the book, you make a mistake and you actually mix 2 words together and form this other hybrid word, and that's normally called a translocation or a genomic rearrangement. Now, in ACC, we know that both of these play a role, specifically in the MYB gene. So we'll talk a little bit about the MYB gene. The MYB gene is composed of these 15 different exons, or you can think of them as the letters that I just showed you, where there is a rearrangement or a translocation event that normally takes this front end of the gene and tacks it on to another gene, which traditionally is either NFIB, RAD51B, or TGF-beta receptor 3, to form these fusion proteins or these fusion words that end up making a completely different product that was intended. This then goes on to enhance its own production in that amplification event. So you end up with multiple copies of this gene or multiple copies of that cat in our illustration. So we started thinking about, well, we know that this is a highly prevalent alteration or driver for these tumors. Could we assay for this signature or this signal for MYB overexpression or amplification in tumors and try and detect who has metastatic lesions and who does not? And in terms of doing that, we decided to develop what are known as a liquid biopsy. So liquid biopsies are biopsies that sample bodily fluids and then test for molecular evidence of disease. Now, liquid biopsies have been developed for any type of tissue in the body, any type of liquid compartment in the body that you can think of. So in our case, saliva or the tear film are the most relevant for head and neck adenoid cystic carcinoma. And the most common ones that you would encounter in the clinic currently are either blood samples or urine samples. And then the question becomes, what molecular space do you want to look for evidence of disease? So if you have a tumor that produces a very well-defined signature of fats or lipids, you could search there. If you know that your tumor has a specific molecule of sugar that it likes or that it needs for its growth, you could assay that molecular space, and the same for proteins or nucleic acids. So in the case of ACC, we decided to look at the low-hanging fruit because, like I said, we know that most of these tumors overexpress MYB, whereas MYB is not heavily expressed in much of the developed body, the other tissues in the body. So maybe that was the low-hanging fruit for us to detect metastatic disease. So with that in mind, we designed this small clinical trial in which we took samples, blood samples, from patients with no known disease, no known cancer ever in their lifetime, ACC patients with a history of ACC, but that had no evidence of disease for longer than 3 years, and their scans were clear of metastatic disease. Newly diagnosed patients with no known metastatic disease, but that did have local disease on presentation, and then patients in which we knew there was metastatic disease or a history of metastatic disease. So we collected about 15 samples for each of these groups. We collected 10 millimeters of blood, so one blood tube out of each patient. We extracted the RNA, and then we designed probes to span the entire MYB gene to look at whether there was any region of the gene that would provide any diagnostic power to detect who had either local or metastatic disease. So if you look at some of the probes that we designed for the different letters or the different exons of the gene, one thing that popped out, and here tumor 1 and tumor 2 were known metastatic disease patients, whereas tumor 3 had been newly diagnosed. And we found this very clear signature, and you can see throughout, this is the one that stands out, where probing or the molecular probes for those first two letters or letters 2 and 3 of the MYB gene produced a very clear signal of metastatic disease patients out of whole blood. So then when we stratified or when we bin patients into these categories that I just told you about, this is what the expression looks like. So we had control patients as well as patients with no evidence of disease, and those gave us our threshold. So that's what we're going to call below this line, we're going to call not suspicious for metastatic disease, whereas patients with known metastatic disease had this very high signature of expression of MYB using these probes for that early part of the gene. So within that, we started to look at what other information this test was telling us, because there were some samples in the different groups that stood out to us. One of them was a patient where his first treatment, so this was a patient that had no evidence of disease for over 5 years and had clear scans at the time of this biopsy, this blood biopsy in February of 2020. However, his levels of MYB were above the threshold, which made us very suspicious for a microscopic metastatic disease that had not been caught by the scans. Now, unfortunately, just a year later, his subsequent scans showed lung mets in his left lung, and then we called him back a month after his scans had shown the lung metastasis, and then his levels were very elevated for MYB. Subsequently, later that year, his scans showed a liver lesion as well, which then further elevated his blood signal for MYB, showing that there was a correlation of the levels of MYB with the mutational burden in this one particular individual. And since then, we've had 3 different individuals in which the test has proven to show a higher level of MYB that would be expected, where the scans show no evidence of disease. And in one case, this case over here, the oncologist actually decided to put the patient on treatment even without having detected a lesion on the scans. And this is over the course of 12 weeks, the patient being treated for what is presumably microscopic disease that we weren't able to detect on the scans. But you can see how over 12 weeks, his signal for MYB in blood has been decreasing, and we keep following this patient up with blood draws every 4 weeks to look at how that resolves. And up to now, we haven't been able to detect anything on his scans, but thankfully his MYB signal in blood has been decreasing. Conversely, we had patients that had a metastatic lesion on scans that fell below the threshold for us to suspect ACC metastatic disease. So this patient number 20 was a patient with a history of lacrimal gland, so multifocal ACC in the head and neck. He had been disease free for 14 years, and we had lost him to follow up, so he had not been coming in for his regular scans, but then started presenting with respiratory symptoms, and his wife brought him in for a persistent cough with some blood in his sputum. And at that time, the CT scan showed two very large lung masses. However, in our test at that time, he kept showing up as very low for MYB signal. So we decided to go back to his tissue biopsies and look at both his primary tumors of the head and neck, which had a very high level of MYB expression, but his lung mass, surprisingly enough, had no MYB. So whereas he was classified as a known metastatic patient for MYB lesions, we weren't able to find MYB expression in that lung mass. So we followed up with the pathologist at his institution who had done the biopsy of the lung tissue, and their final diagnosis was actually a different type of tumor that had grown in his lungs, a different primary called a non-small cell lung cancer, which is another epithelial tumor, and it arises because of this other mutation, or this was the mutation in this patient. Then we learned that the patient had been a heavy smoker all his life and never quit, even despite having that history of ACC. So the blood sample or the blood test at the time, we classified him as an ACC metastatic patient, but it turned out that the lesion was not ACC, it was a different epithelial tumor, which showed that maybe the blood test was still very specific to ACC signatures. However, as I mentioned before, we know that there are some tissues in the body that express MYB, and these include the bone marrow. So we decided to look at whether our test was actually picking up an ACC specific signature through reading of that junction between those two letters 2 and 3 of the MYB gene, or whether it was more specific to MYB in general. So we decided to test the letters 14 and 15 of the MYB gene, which would correlate or would be normally expressed in bone marrow as well. As you can see here, there is no difference between the level of expression in controls, patients with ACC and no evidence of disease, or metastatic patients when we probe for this latter part of the gene, which is normally lost in translocation events or silenced in ACC because it contains the regulatory regions for the tumors. So we still believe that probing in this region over here is giving us a very specific, an ACC specific signature for MYB. And that I'll talk a little bit about that later, how that's translating into novel therapies, because we know that in ACC there is what's known as an alternate promoter that exists in exon 2, where the tumors actually start reading the gene from this second letter, bypassing that first one. So there's a huge spike in reads that occurs between these two first letters in ACC specifically, which we are actually leveraging as a tumor vulnerability to develop some therapeutic agents against it. So from here, we decided to look at, well, where is this MYB signal actually coming from in blood? We've been testing whole blood, but we know that blood is not a homogeneous tissue. It has multiple different compartments. So we took, again, samples from the 4 different cohorts, specifically from metastatic disease patients. We were very focused on those. But this time we separated out the blood into the liquid compartment, which is the plasma compartment in blood, and into the 2 cellular fractions, the mononuclear cells in the blood, which would include your immune cells. And then we excluded the red blood cells because those normally don't have DNA, they don't have a nucleus. So there's very little transcription that occurs in those. So when we checked both the plasma and the PBMCs through our test, and here's the results on the right-hand side here, you can see the levels in whole blood are elevated compared to control, but when we compare or when we fractionate the blood, you can see that the true signal is actually coming from the cellular level compartment in blood. So that gave us two alternative hypotheses. One, maybe we had immune cells that had gobbled up dying ACCs. So normally cancers, as they multiply, they apoptose, or they break apart, and immune cells will go in and clear that up and take up some of those molecules. So maybe that's what we were seeing was immune cells that had taken up some of these molecules, and that's where the signal was coming from. Or we actually had ACC cells circulating in the blood in metastatic patients. So in order to discern that, we took the bone marrow, sorry, the mononuclear cell fraction, and we did what is known as single cell sequencing. And for those of you that are not familiar with single cell sequencing, each one of these dots here represents a single cell, and we're mapping what's known as the principal components in RNA-seq. So we sequence the whole RNA space in each one of these cells, and based on what they're expressing, right, based on what parts of that book are being read, we can identify different cellular compartments, different types of cells within the blood. So you have your CD4 regulatory cells, or your CD4 T lymphocytes, your CD8s, your NK cells, as well as your beta cells, all the cells that you would expect to find in blood. But there were two groups or two clusters of cells that we were not able to identify based on their expression, or what parts of the book, what they were expressing, what parts of those books were being read. So we decided to look at MYB, the gene MYB, in all of these clusters, and see if there was any one cluster that actually was contributing to that signal. And as you can see here, the results were very clear that this cluster of interest here, isolated by itself, was the culprit for the entire signal of MYB that we were looking at. So we decided to focus closer on this cluster, analyze the signature of all the genes that were being read there, and then went back to our pathology slide and mapped that signature against all the signatures in these different types of tissue in the tissue biopsy. And when we mapped, for example, the CD4, so the lymphocytes within this spatial cluster, you can see that they map around the areas of cancer, but they were very low in the cancer. Whereas that cluster of interest mapped perfectly to the areas of the pathologist confirmed cancer regions, highlighted in purple in this H&E over here. So what we had identified really in this cluster of interest was a circulating tumor cell population. So there's actually ACC cells floating around in the blood, which provide this very heavy signal for MYB in metastatic disease patients. So we label those as circulating tumor cells, and that's what we're actually detecting on our blood test. So what have we learned so far, and how are we translating this into the clinic? So we know that the MYB levels in blood correlate very well with metastatic disease in adenoid cystic carcinoma. So far, our test has proven to give us a greater than 94% diagnostic power in stratifying local versus metastatic disease patients. So this allows us, like I showed you in the couple of examples, to know which patients need more subsequent follow-up for imaging, or if the oncologist decides to initiate treatment before any known lesions are seen in imaging, this could be a powerful tool for them to look at or rely on to justify that rationale. This is done through a PCR test. So think of a COVID test, which is a very rapid test. It's a very inexpensive test out of a single tube of blood. So whenever you go to get blood work done, they draw multiple tubes of blood. All we need is a single tube of blood. PCR can be done in around 3 hours. And like I said, it's very cost effective and simple to run. Most diagnostic labs and some doctors' offices actually have PCR machines where this test could be done. The MYB signal that we are detecting arises from a circulating tumor cells in the blood. So there's ACC cells floating around in the blood before they actually colonize a specific metastatic site. And like I said, these CTC signatures, or what the circulating tumor cells in ACC are actually expressing, are providing further insights into mechanisms for how these tumors actually undergo metastases, which could then inform, or is now informing, new therapeutic avenues to try and prevent metastatic disease from developing upon newly diagnosed ACC. And that ACC specific MYB regulation that I showed you, where those letters, that letter 2, that exon 2 has that alternate promoter active in ACC, can be leveraged as a vulnerability in what are known as oncolytic virus therapy. So these are viruses that are designed to deliver a gene therapy. In this case, it's a detrimental gene therapy. It's a gene therapy meant to kill cells. And we can harness what the tumors are using to regulate their main driver to drive what's known as a suicide gene. So basically, we use that alternate promoter in MYB to drive something that will kill cancer cells and spare normal cells. So, and that's the graph that you see to the right here, some of the results that have been going with our oncolytic virus therapy, where we use that alternate promoter that we found in ACC, and with the combination of an enzyme plus a prodrug, either which by themselves is not cytotoxic, anybody can take them without any effects, but the combination of them becomes toxic to cells. So that way, when we infect either normal epithelial cells, primary ACC tumor cells, or metastatic cells, you can see that we can spare cells. So this is a chart of cell viability. Normal cells are not affected by this tumor infiltration and this detrimental gene therapy, whereas we can actually kill primary ACC tumor cells, and more so a couple logs, a couple order of magnitudes in concentration lower, we can actually kill metastatic cells. So the other thing is, we've learned that liquid biopsies can also serve for primary tumor diagnoses. Right now we have data showing that tear and saliva can serve as a reservoir for molecular signatures to distinguish adenoid cystic carcinoma from other lesions that are part of the differential diagnoses. So we've tested adenoid cystic carcinoma in microRNA signatures from adenoid cystic carcinoma tears and saliva against pleomorphic adenoma, lymphomas, and inflammatory diseases of these glands. And we have these very nice differential volcano plots showing a differential signature both of upregulated and downregulated microRNAs, which we hope to build as a panel to distinguish, again, that primary diagnosis of the tumor, and presumably would help for the detection of recurrence of the disease as well. And what we have right now, in order to transition the blood test into the clinic, is we've started a clinical trial for the blood test, which looks a little bit like this. And I'm sorry if it's a little confusing, but in the head and neck, as well as the ophthalmology services, both here at Sylvester and then another site in Latin America that we've been able to onboard, we've been taking blood samples from patients with a benign diagnosis. So these are more inflammatory diseases of the glands, patients with other head and neck or ocular cancers, not ACC. We've collected blood from both of those. And within the ACC cohort, again, we have a newly diagnosed cohort of patients with a history of ACC, but no known mets at the time of blood collection, and known metastatic patients with known metastases through imaging at the time of collection. We collect blood, we're doing the RNA extraction, and in the lab, we call the molecular diagnoses. So we make the diagnosis based on our blood test. By the way, we are masked as to the identity of each sample. So we only get these coded We make a molecular diagnosis based on our blood test, and at the end of the trial, we will unmask the data and match our results to the actual medical history of each one of these patients that we've collected blood for. And in the ACC cohorts, for the patients that have a history of ACC but no evidence of disease for more than 3 years, or those with metastatic disease, we're doing a longer term follow-up where we're collecting blood every 6 months for up to 3 years, both to track the levels of ACC in the blood test to see how those correlate with treatment or get altered with treatment or progression of the disease. And an additional blood unit we're using to isolate these circulating tumor cells that we've identified in order to do a more comprehensive drug screening, because like I said, we found within the signature of what these circulating tumor cells express a couple of actionable targets that we believe will be amenable for the treatment of metastatic ACC. With that, I will just thank my lab team, the current as well as previous members that have worked on this, the collaborators in all of the clinical trial sites, and our funding sources, not the least of which has been ACCRF. Nikki and Jeff have been very supportive of our work throughout the years. And I'll take any questions.
Okay, so for the sake of time, I have a couple questions, and then we can maybe see if there's some questions in the room.
Yes.
Okay, so do you foresee liquid biopsies replacing CT or MRI imaging in the future?
I do not. So here's the nuance behind both of those. The blood biopsy allows us to stratify patients to know who needs to be more closely monitored. And like I said, in the case where the medical oncologist feels it's pertinent to begin treatment even before the imaging studies show a lesion, that's fine. But the imaging studies do provide that location, right? So we can only see whether there's increased MYB levels and that's suspicious for metastatic disease, but the blood test does not allow us to tell where the disease is, right? So whether it's a liver lesion, a lung lesion, or a bone met, that's not something that we can discern or glean from the blood test.
What about forgoing a biopsy? The need for like a biopsy of a metastasis?
So that, again, is going to be dependent on the outcomes of the clinical trial. So depending on the diagnostic power that we end up with from the clinical trial, we might advocate for the changing of guidelines where this can supersede the need for a biopsy, yeah, for ultimate diagnoses, yeah.
Can you talk a little bit more about, what steps need to happen between now and, all the patients in this room being able to use or have access to the liquid biopsy?
So in terms of the clinical trial right now, we are trying to onboard additional sites, some of the bigger referral centers, so your MD Andersons and stuff like that, sites like that, so that more patients have access, at least to the clinical trial where we can draw blood from them. The limitations there, obviously, funding and getting clinical coordinators and logistics at each one of those sites. But we have engaged a couple of the sites and have gotten a lot of interest. So soon enough, hopefully, we'll have a site near you guys where you can go and get your blood tested.
And the last question I had is how do you think a liquid biomarker could be used for patients during a clinical trial? Maybe including, we have these novel MIB inhibitors that are being tested now. So how useful could the liquid biomarker be?
So at least in our case, and in the one sample that I showed you where we started treatment before the lesion was actually detected in imaging, we've seen that the diagnostic test is a very good companion test to look at effectiveness of, well, what we believe is effectiveness of the treatment, and looking at the burden of MYB or those circulating tumor cells in the blood as the patient is being treated. How MYB specific targeting drugs will affect the readout of the blood test remains to be seen, and we'll see that. Hopefully we get a large enough cohort of those patients in the clinical trial to be able to do the sub-analysis of that there.
For the blood tests, are you using primers made for each person's specific MIB fusion, or are you using more general primers that work for MIB in most people?
So right now we have general primers, and like I said, we are focused on this one region of the gene that seems to be made more accessible because of the translocations that occur, and that seems to be irrespective of the individual downstream translocations. But there's no reason that we couldn't design primers for specific alterations, and we've had that discussion internally, whether we build a repertoire or armamentarium of primers that would cover most of the known translocation events. Yes.
All right. Thank you, Dr. Pelaez, so much for your time today.